I'd like to invite our next speaker, Dr. S. Ambika, who is the head of the Department of Neuro-Ophthalmology at Shankar Nethralaya, Chennai. She'll be speaking on IIH treatment strategies.
Good afternoon, all of you. First of all, let me thank the organizers for this opportunity. Well, I'm going to talk on IIH treatment strategy. So IIH is no longer a benign condition and it can cause a permanent vision loss and a chronic headaches. But main goal of the treatment remains in alleviating the symptoms and preserve and restore the vision. So early medical treatment and weight reduction can save vision in typical IIH, but there is a lack of consensus as which best surgical approach would you choose in a refractile IIH. And weight gain is the main known risk factor in a typical IIH and also its recurrence. So the IIH weight hypertension trial has also discussed about the options of trying bariatric surgeries in the effective management of a long-term typical IIH. And you all are aware of this Dandy's modified criteria, which is the diagnostic criteria to make the diagnosis of IIH. So this is a nice infographic summary what you can use for your patients. I have given the reference. This is a very nice chart which you can use. Here you could start identify that as the diagnosis of papilledema, do the optic nerve function test, and always check blood pressure when you see a bilateral disc edema and confirm that you're dealing only with a papilledema. And if it is going to be then escalated to a neuroimaging, and in case of IIH, there's always you need an MRI brain and orbit with contrast with an MR venogram. So without MR venogram, do not go ahead and treat a so-called diagnosed IIH. So rule out other venous anomalies before escalating to the lumbar puncture. And depending on the CSF opening pressure, ruling out the secondary causes, you can plan the treatment for a typical IIH. So the management strategy is, as I mentioned, it's to protect the vision and then manage the underlying disease. So if there is a classical weight-bearing, the reproductive age group and overweight female, go ahead for weight reduction and then continue the IIH management. And what type of manifestation? If the headache is quite severe in a presentation, you concentrate on the headache management. But if it is a typical IIH, generally they have a very chronic nature of visual loss, unlike the atypical IIH, which you have to be very careful because that can move on to this group of fulminant IIH very faster. So these group of patients are the one you have to keep in close follow-up. You can put them on a temporary lumbar drain if you're going to plan the surgery. And if you see a very fastly escalating vision loss and a visual field loss, go on for a CSF diversion procedure or a sheath fenestration, depending on the facilities available in your center. So I'm going to start with a case, which is a 26-year-old female. She, in fact, was an ENT doctor. She presented to us with 20 days old of drop-in vision, gradually worsening. She apparently had a food poisoning after one of her department get-togethers, following which she developed this. And she was diagnosed to have an IIH locally, and she was put on Diamox. She was on 500 milligram daily dosage and a small dose of oral steroid as well as topiramate when I saw her first. She was a moderate built, non-obese female, and her vision was normal and color vision was normal. But when I could see the fundus, this was the disc appearance for her. She had a significant disc edema. Already there was a pallor setting in with a hemorrhage. And this was the visual field where you could see that there is definitely significant peripheral loss in both the eyes. So the OCT showed almost an RNFL thickness, which is almost beyond 300 plus in both the eyes, and some amount of ganglion cell loss you could see over here. And MRI brain and orbit revealed a normal, it showed classical IIH features like perioptic space widening and empty cella. And apparently the MR venogram was normal. And her spine screening also was normal. So we went ahead and did an LP, which showed a CSF pressure of almost 300 millimeters of water. So we told probably you're having a chronic papilledema, which is escalating now. So we may have to increase your dose of Diamox. After the neurologist and neurosurgeon concurrent opinions, we went ahead and did this. We called her after 4 weeks, but she turned out after 6 weeks. And you could see there's a visible reduction of a disc edema in both the eyes when we escalated the Diamox to 2 grams. And this was a visual field. There was a significant improvement in the visual field indexes after the escalated Diamox dose, and this is 3 months follow-up, and she remained 6, and 6, and now we stepped down the Diamox to 1.5 gram per day as she had some difficulty in taking, and her visual field still remained having few peripheral defects. So this was a pre-treatment OCT RNFL thickness you can see here. But you can see there's a definite RNFL thickness lowering, but there is also a progression of the ganglion cell loss on the macular cube, what we saw. So this one study in Neurology 2023 had shown some prognostic factors. So they did a longitudinal prospective trial, and they found 98% of their study population were female, and highest OCT RNFL layer had the worst visual outcome. And a change in BMI had definite impact on the treatment options, whatever you choose in a chronic IIH. So we also had done this way back in 2010. We did in our Indian population, we studied almost 106 patients, and 50 of them fulfilled the criteria, and we found that most of them were less than 50 years, and all of them had significantly normal vision on presentation, and 92% had bilateral presentation, normal MRI, and an early enlarged blind spot as a presenting field defect in most of the eyes. Only 18 eyes had a visual acuity of less than 660, whereas they presented quite late in the disease onset. So they had a vintage papilledema with a grossly dropped visual fields. At that time, we escalated these patients. Apart from medical treatment, we had to give the other options of surgical interventions also. So topiramate can be considered as a second line of management following Diamox, and particularly when there is a headache as a presentation, most of the neurologists do prefer. But remember the red flags of IIH: a male patient, non-obese, venous sinus disorders, any blood dyscrasias, and drugs. You have to watch out for these are the red flags where they may not fall the classical IIH presentation. And there are a lot of drugs which are coming up in the literature, like exenatide, which has been used to reduce the ICP, and it has also shown improving in symptoms. But venous sinus stenting has got increased popularity when it is associated commonly with a atypical IIH. When you see an venous sinus stenosis, you have to consider for the stenting in addition to the CSF diversion procedures. And the dual benefits of weight loss and ICP reduction with exenatide have increased its role, and probably it promises for the future management options for IIH. With this, I try to conclude, and I like to invite you all for the 6th annual Indian Neuro-Ophthalmology Society meeting, which is going to be held at Shankar Nethralaya, Chennai. Hope to see you all in Chennai. Thank you.
Thank you, Dr. Ambika. I'll take a couple of questions from the audience, if there are any. Yes, sir.
Dr. Ambika, I just want to know seriously, how do you exactly plan the Diamox? What dose to start with, when to step down or taper up, and how long to continue? Please.
I think that is too subjective, because this patient was on a mosquito dose of Diamox by the time I saw, because she's having a significant visual field involvement and already chronic disc edema with pallor, and vision is almost any time, and this is the first time I'm seeing her. So I do not know whether she's going to respond, because my next step is going to be the surgical advice if she's going to grossly drop in vision. So these patients, if you're going to have a good vision, good visual field, and you're the first time you're advising no MR venogram abnormality, probably you can ask again, if your neurologist is going to advise a lumbar puncture, see what type of CSF pressure you're going to encountering. If you're going to have a very gross disc edema with a very high CSF pressure, most of the time they may start with somewhere between 1 gram to 1.5 gram. And it also depends on whether your patient is able to tolerate it. But usually they start with 500 and they gradually increase the dose. That's the pattern what I have seen. Particularly, you can tell your neurologist if there is no gross visual field deficit. But if, like this patient, if there is a gross deficit, most of us would agree that you may have to increase the Diamox. Since our patient was already on a 500 milligram for a longer while, we escalated gradually within 2 weeks to 2 grams of Diamox. That's how we plan.
How long you wait to taper it down or step down that?
If my visions, all optic nerve functions are maintained, probably I'll give a very gradual taper. I may not taper it very sooner. And whether she's in a typical IIH like obese, motivate for the weight loss and follow them over maybe 6 months to a year, I have seen patients of more than two years also on Diamox, where we give a very slow taper, provided they are maintaining their vision and the visual fields.
And the continuation of Diamox since
That's
how long?
what. If your patient is going to have, maybe you increase to the dose. If you see visible reduction of the disc edema, vision is maintaining, fields is maintaining, you can gradually pull them off the Diamox. It's too subjective, doctor.
And the dose differs whether the patient is overweight or not. It's normal.
Maybe I would depend than that if whether the nature, the vision drop has happened in her. If it's a typical IH also, if I'm seeing in a very chronic stage, I may not advise to go with a small dose of Diamox for a longer period. I may escalate to a higher dose. Maybe if I'm going to plan for the surgical procedure in a shorter interval, I will also advise for a lumbar drain and keep her in a watch and then immediately flip over to a surgical treatment rather than keeping a chronic Diamox dose.
Thank you.
Thank you.
Dr. Ambika, was this patient IIH or do you think it was something else?
Actually, we thought she had some meningism features because she presented acutely with a food poisoning, and that was a trigger which we had. She had a CSF which did not have any meningitic nature, and at that time she told me that yes, 1 year back one of my neurology friends had told that I have subtle disc edema. And that's when we asked, like, you are already an ENT doctor, and how did you let go that there was a subtle disc edema? She said, Madam, I didn't give this as a great importance, but after the food poisoning, she really worsened down a lot. Maybe that has made her worry about her vision.
Yeah, so it is relatively common for people to have triggers after upper respiratory tract infection or even GI bugs, and we think it's some form of subclinical aseptic meningitis. In aseptic meningitis, your CSF is going to be clean. You don't find anything, but the inflammation has caused the ICP to go up in these patients. But the answer to one of the questions is the dose of acetazolamide, it doesn't depend upon the underlying cause of the papilledema. It just depends on the visual function at presentation.